Mr. Karan Singh, Dr. Arun K. Agarwal, and our Director General, Mr. Arun Chawla. I would also like to welcome the dignitaries and panelists who have joined us virtually. Shri Amit Mohan Prasad, Additional Chief Secretary, Department of Health and Family Welfare, Government of Uttar Pradesh. Mr. Neeraj Bansod, Director Health Services, Government of Chhattisgarh. Dr. Sabahat Azim, Co-Chair, Primary Health Subgroup of FICCI, Co-Founder and CEO International, UP Health, and Founder and Chairman, Global Health Systems. Dr. Sunil Raina, National Convener, OMAG, Project Director, CATCH, and Professor and Head Community Medicine, Dr. RPGMC, Kangra, Himachal Pradesh. And Mr. Suresh Vazirani, Founder Chairman, Transasia Airba Group. Today, we have gathered for a very significant initiative through which we intend to support the Government of India and state government by facilitating smart health and wellness centers. Also, although there have been many instances where private sector has collaborated and partnered with state governments to support and manage the Ayushman Bharat health and wellness centers across the country, but this is the first time ever that the private sector and healthcare industry have joined hands to collaboratively work towards enhancing primary healthcare in India. With this, may I now request our Director General, Mr. Arun Chawla ji, to please present the green certificate to our chief guest, Shri Rajesh Bhushan sir. This is a commitment from FICCI that we'll be planting 6 trees at Sundarbans National Park, West Bengal. Shri Bhushan is an IAS officer of 1987 batch Bihar cadre. Prior to this, Mr. Bhushan was Secretary of Ministry of Rural Development and also in the Cabinet Secretariat. Thank you, sir. I would now request our Director General, Mr. Chawla, to please give his welcome address.
Shri Rajesh Bhushan, Secretary, Health and Family Welfare, Government of India, other dignitaries on the dais, ladies and gentlemen. On behalf of FICCI, it gives me immense pleasure to welcome you all to this important seminar on transforming primary healthcare in India through Ayushman Bharat Health and Wellness Centers. We are privileged to have the presence of Shri Rajesh Bhushan, Secretary, Health and Family Welfare, Government of India on this occasion. Thank you, Honorable Secretary, for taking time out from your busy schedule and to support this program and initiative. You have been the key driving force for many of the recent initiatives of the Ministry of Health and have always provided encouragement to the industry members through your vision and wisdom. I am also delighted to welcome all other dignitaries, panelists, and speakers to this event. Ladies and gentlemen, over the years, Government of India has explicitly recognized that primary health care is a key lever and only affordable and effective way to achieve sustainable development goal of good health and well-being, as well as the universal health coverage. This announcement of upgradation of primary health centers and sub-centers to Ayushman Bharat Health and Wellness Centers in 2018 was a remarkable step for the betterment of primary care in the country. This was envisioned by the Honorable Prime Minister Shri Narendra Modi to help provide affordable and accessible health care to the last mile. These health and wellness centers are now recognized as the largest reform in primary health care since India's independence. More than 1.17 lakhs health and wellness centers have been operationalized, and the government is well on track to operationalize another 1.5 lakh centers by end of 2022. This is commendable, especially considering that the government has also been battling against COVID-19 pandemic for over 2 years now. While substantial progress has been made in operationalizing the health and wellness centers, there is still huge scope of work in this area. The government has sought participation from the private sector to make this program a success. Hence, FICCI's Swasth Bharat Task Force is keen on supporting the mission to make 1.5 lakh centers fully functional. Ladies and gentlemen, FICCI has now joined hands with NatHealth and OMAG to work in 2 states, Uttar Pradesh and Chhattisgarh, to create demonstration models of smart health and wellness centers in association with the respective state National Health Mission. We are delighted to have the presence of Shri Amit Mohan Prasad, Additional Chief Secretary, Department of Health and Family Welfare, Government of Uttar Pradesh, and Mr. Neeraj Bansod, Director Health Services, Government of Chhattisgarh. Both of them have joined us virtually. These smart health and wellness centers will provide the full suite of services envisioned under the scope of comprehensive primary health care, leveraging technological innovations. Today's seminar is a launch for this smart initiative. I request all the industry members to support this initiative and work with us to enhance primary health care in India. I would also urge the private sector, our industry members, to come forward and use the CSR funds towards the development of smart health and wellness centers. Let me at this stage acknowledge the immense contribution, especially our chair, Dr. Arvind Lal, and the committee members of FICCI, Swasth Bharat Task Force to this initiative. Once again, I welcome all of you and wish the ensuing deliberations all the success. Thank you.
Thank you, DG sir. I just wanted to apprise that owing to the COVID protocols, we have large number of audience which have also joined us online. May I now invite Honorary Brigadier Dr. Arvind Lal, Chair of the FICCI Swasth Bharat Task Force and the Managing Trustee of ALVL Foundation, and the Executive Chairman of Dr. Lal Path Labs. He has been awarded with Padam Shri in 2009, and he is also the first civilian doctor to be granted an honorary brigadier's rank in the Armed Forces Medical Services in 2009. Dr. Lal, may I please invite you for your opening remarks?
Mr. Amit Mohan Prasad is on the line. He says he's not able to work the camera. Good morning, ladies and gentlemen. I welcome you all to this path-breaking FICCI seminar on transforming healthcare through HWCs or health and wellness centers. I am honored and delighted to welcome our chief guest, Shri Rajesh Bhushan sir, Secretary, Ministry of Health and Family Welfare, Government of India, and our guests of honor, Shri Amit Mohan Prasad, Additional Chief Secretary, Department of Health and Family Welfare, Government of Uttar Pradesh, joining us virtually. Actually, he was just trying to join me. That is how I was on the telephone. And Mr. Neeraj Bansod, IAS, Director Health Services, Government of Chhattisgarh, from Raipur, who has been nominated by his Principal Secretary, Dr. Maninder Kaur Dwivedi, to represent Chhattisgarh on this seminar. And last but not the least, my respected health industry colleagues from FICCI, from NAT Health, and OMAG, which stands for Organized Medicine Academic Guild. FICCI has been working in the health sector for nearly 2 decades, and since 2018, I have been the chair of various health committees of FICCI. It was a special call for me last year when I was requested to chair the FICCI Swasth Bharat or Primary Health Task Force. In 2017 and 18, a mega reform in the history of healthcare in India was announced in the form of Ayushman Bharat, with its twin pillars giving equal importance to primary healthcare under the Health and Wellness Centers program, as well as hospitalization, secondary and tertiary care programs through Pradhan Mantri Jan Arogya Yojana or PMJ. In the Union Budget 2018, during the announcement of creation of 1.5 lakhs HWCs, the then Finance Minister, late Shri Arun Jaitley, invited the private sector to partner in HWCs through their CSR and philanthropic activities. The Honorable Prime Minister has also urged the health sector to focus on improving health and wellness services in the rural areas. As a platform for industry convergence, FICCI took the lead to further this cause as an industry-wide movement and brought on board NAT Health and OMAG, that is Organized Medical Academic Guild, for the first time in the history of Indian healthcare industry. These three very prominent associations have joined forces through their 300 plus health sector member organizations to work with the government to create demonstration models of smart HWCs in the true sense of collaborate, operate and transfer in the two prominent states of Uttar Pradesh and Chhattisgarh. It's a matter of great pride for the entire private healthcare industry that they have come together in a spirit of cooperation and collaboration in helping the government to transform primary healthcare in India. For the government, this is an entirely new phase of the private health sector that it has not come to, quote unquote, to earn revenue from a PPP, which is usually the case when the two come together. At this point, I would like to reiterate that the private sector will be partners of the government in these HWCs and will not be taking them over. The private sector will act as a catalyst to only bridge the gaps in functioning of these HWCs, dedicating our blood, sweat and tears, or what we say in Hindi as tan, man and dhan. The beginning of this collaboration was made in early 2020 when my wife, Dr. Vandana Lal, who is here, Vandana, would you please stand for a moment? Dr. Vandana Lal and I started a new journey with our philanthropic initiative, ALVL Foundation or Arvind Lal Vandana Lal Foundation, with a vision to contribute to better primary healthcare services for the underprivileged and vulnerable population, especially those living in the remote areas of the country and rural areas. We started working with the government of Uttarakhand as their partners in 10 health and wellness centers in Almora district with the aim to develop these HWCs as demonstration models or smart HWCs and support them in bridging the gaps and providing the full scope of services envisioned in the scope of HWCs. I will be sharing more details about this in the panel discussion. After successfully working for over a year with the Uttarakhand government, we shared our experience with some industry colleagues who are all present here, who were more than thrilled to learn about smart HWCs and were eager to know how they could also join hands to make it more impactful. We also learned about several other organizations who had been working on similar initiatives. Through this FICCI, NatHealth and OMAC platforms, members of health sector have come together and are committed to contribute their expertise, experience, and financial resources in the form of CSR and philanthropic funds to this collaboration. As far as the managerial expertise is concerned, I would like to add that one of our FICCI members is IIM Ahmedabad. FICCI is in discussion with both these states for signing MOUs for partnering 30 HWCs in UP and 10 HWCs in Chhattisgarh. And once the model is proven successful in UP and Chhattisgarh, like the success in Uttarakhand, this smart HWC project can be expanded in more states gradually. Thank you very much.
Thank you so much, Dr. Lal. May I now invite Mr. Sanjeev Navangul, Chair of NetHealth West Region, MD and CEO Bharat Serums, to give his remarks. We've partnered with NetHealth on this initiative, so welcome, Sanjeev.
Thank you. Good morning, everyone, dignitaries on the dais and the audience. Yeah, when you look at this audience and the dignitaries, once on this topic, it feels like you're preaching the choir. I think all of us probably are much aware of how this, what we need to do. But to say a few things, I think the importance of primary care cannot be underestimated in any country, especially with a population of our size. We also know that if we have to go from sick care to health care, the health and wellness centers are probably the most important step that the government can take along with private sector to ensure that we really move there. It's always a healthy nation is a wealthy nation. It's probably not true the reverse. We see some countries and we know that the reverse may not be true. As we look at our ambition, there are a few things that we know there are gaps in what we can do at the moment in health and wellness centers. Those gaps are not something which are surprising or suddenly dawned on us, but there are certainly some gaps that we need to fill. To name a few, there is financing gap, there is sometimes manpower gap, there is governance gap, there is low utilization in many places, low tech. I think one of the biggest issues is low tech. And as private sector participation, as Nat Health, some of the expertise that we can bring to the table, one is CSR funds everybody talks about. But I think when organizations such as Nat Health or somebody in the industry, when we talk about helping, we also need to talk about our expertise and what we bring to the table. And therefore, we believe that how do we incentivize the whole system to produce better results? How do we help manage the whole system better? How do we get community engagement at a much higher level? Because unless there is community engagement, utilization will not go up. And if utilization doesn't go up, we don't get to the SDG 3 goals. So there is a lot more that we need to do in terms of community development and community engagement. And therefore, the involvement of private sector can support the government in trying to ensure that we do a lot more about it. The next big thing that obviously private sector can bring is technology. I think the way the whole digital system can work with the private sector involvement could build a lot more efficiency, a lot more support, a lot more connectivity to the whole system in a much, much better way. And therefore, I think one factor we need to consider is how we can bring in more technology and more digital engagement through the private sector. And obviously, the whole idea in private sector is all about performance monitoring, and therefore the performance monitoring thinking is something that we can bring to the table. Obviously, many of these things should lead us to expand coverage, invest in system capacity, increase efficiency, and that is probably very, very important to ensure that we increase efficiency. We also mitigate kinds of risks that we see in the system. And clearly what is most important is save future cost. I think the cost of healthcare dramatically goes up from primary care to secondary care to tertiary care. And if we really manage a lot of stuff at the primary care, the kind of cost that people incur and therefore the whole catastrophic situation that arises out of those costs can certainly be managed better. So, and there are several examples, I think, that have happened world over. You see a lot of things that happened in Turkey or in Brazil where you see a lot of impact on cost saving that happened with people in their household incomes or household disposable incomes when they ended up having a greater primary care system. So to end, I think the ability of private sector to bring in a lot of things to support the government in health and wellness sector is well established. The point is that we need to start somewhere, and I'm very happy about being here today, that we are able to start the discussion around this topic and ensure that we participate in a much stronger way to help a couple of states get to better health goals. Thank you very much.
Thank you, Mr. Navangul, and FICCI is privileged to partner with Net Health on this, and also partner with OMAG. May I now invite Dr. Sunila Garg, immediate past president, Organized Medicine Academic Guild, Professor of Excellence and Chair, Program Advisory Committee, NIHFW, and Dr. Garg has been advising FICCI on various public health issues. Ma'am.
My laptop presentation, I need to use that presentation. Yeah, somebody loaded the, now. Somebody has loaded the presentation. Yeah, it's here, but how to operate it? The presentation is here. Yeah.
So, ma'am, would you like to sit there and
I can, yeah.
and just keep saying next slide?
I think you can move to the next slide. Good morning, everyone. Respected Chief Guest, Mr. Rajesh Bhushanji, Secretary, Ministry of Health and Family Welfare. Shri Amit Mohan Prasadji, Additional Secretary, Department of Health and Family Welfare, Government of Uttar Pradesh. Mr. Neeraj Bansod, Director, Health Services, Government of Chhattisgarh. Brigadier Arvind Lal, Chair, FICCI Swasth Bharat Task Force. Mr. Sanjeev Navangul, who is Chair of Nat Health. Mr. Arun Chawla, Director General, FICCI. Then also, we have, very, very eminent people amongst us, Dr. Sabat Azam, my colleague, Dr. Sunil Raina, Dr. Suresh Wazirani, and Madam Meenakshi Datta Ghosh, and along with Dr. Arun Agarwal, where we have spent decades together, in addressing primary healthcare, and I think we started this journey together. and primarily when we were talking about primary health care. So, one of the most important things, everybody would be wondering, what is this Organized Medicine Academic Guild? Now, this is I'll bring to the attention of Honorable Secretary Health, sir, this is a guild of associations, which is, a dream child of Dr. Sagar Galvankar, who is based in Florida, where we thought and brainstormed about that there is a need of professional associations to come together. Because you see, we cannot work in isolation or silos. So this is where, along with CDC Atlanta and NCDC, the different professional associations, right from Indian Association of Preventive and Social Medicine, for which I was the also president in 2021 and President OMAG. So till emergency medicine, because pandemic has taught us that we need to come together horizontally, not vertically. So that is where, and we need to address the primary care issues as well. So this is where, when the time is there, I will give a detailed presentation of what OMAG is, how we are working together, and how we are addressing pandemic preparedness, global health security, antimicrobial resistance, and all that. So today, now the current president is one of the anesthetists, because he's also learning about what is primary health care. So that's where we need to, understand more and more about our horizontal integration. So as far as, the role of private sector comes, it becomes very, very crucial to be a partner to, under Health and Wellness Center addressing Ayushman Bharat, which was, recommended not now. It is a part of national health policy to achieve the vision of universal health coverage. And not only, let me tell you, when we are talking now in 2017, India has been talking about this since 1978, when there was Elma Ata Declaration. When we talked about primary health care, it should reach the last mile through the affordability and means, which everybody can, afford to have the primary or basic health care. So our basic principle is that we should leave no one behind. And then from sectoral and segmented approach of healthcare delivery, we have to go to comprehensive need-based healthcare service. And holistically, we have to address, the preventive, promotive, and curative care services at all levels. So at the basic level, when we have got health and wellness centers, so linkages are there through PMJY and all that. Next slide, please. So that is one of the important things. So in 2018, we had announcement of, 150,000 health and wellness centers. So as of now, we have got almost 117,000 which are there. But then, they're there in bits and parts. So that's one of the crucial things which we'll be doing in the beginning, is what is known as gap analysis. And then another important thing is that, the key features of the program are to transfer the existing health centers, that is what we used to call as sub-center for 5,000 population. Those of you who are from the medical background will remember the community medicine people talking about sub-centers, primary health centers, then block hospital, Jilla hospital, district hospital, and all that. We have got a very India is, I'll say, that has got the best healthcare delivery system. Only thing is we are large in population. So this is the dream of our Honorable Prime Minister, to reach the last mile. And I'm very happy that PK has taken the lead in this direction. So we have to also enable, the focus is not only on creating the healthcare, but enable the high quality healthcare through availability of medicines, diagnostics, use of standard treatment guidelines, referral protocols, and available technologies, including IT systems, and focus on wellness. When we are talking about smart and health and wellness centers, when we are talking of 30 in UP and 10 in Chhattisgarh, we will be evaluating against all of these, what I mentioned. And also, another important part of this is, community engagement. So we are going to focus on health promotion, and already, and who are our, ambassadors, our school children. So, there's a lot of focus on involvement of school education and individual-centric awareness and promotion of yoga and other wellness activities, which also will be evaluated and implemented, and promote public health through active engagement and capacity building of community platforms and individual volunteers. And also will be facilitating the use of appropriate technology for improving access to healthcare advice and treatment initiation, and enable reporting and recording, eventually progressing to electronic records. Few of the states have already done, like Tamil Nadu, Karnataka, and all, where digitalization is almost 100%. So our health management information system is quite very strong. And we also have to institutionalize the community ownership and management of health centers through Jan Arogya Samiti. So that's where community's involvement is there. Next, please. So, we all know that now only sub-center, all of you, if you remember in your memory, and because I have got 4 decades of experience in public health, so every time we talked of only reproductive and child health. So, and all the, newborn care and all that. But now, we have moved on much beyond that, to family planning, contraceptive services. We have started talking of management of communicable, non-communicable diseases. Apart from that, we have talked about, screening, prevention, control, management of, not only non-communicable diseases, but mental health illnesses, which now pandemic has demonstrated how important is mental health. Apart from that, ophthalmic and ENT services have become the core of services also at health and wellness centers, basic oral health care, elderly and palliative health care, and I'm very happy that FICCI brought out this white paper at a very timely point, that means we have addressed the elderly also just before, a few months back we came out with the document, and also emergency medical services and the referral that becomes very important. So these are the expanded range of services which will be assessed, when the first important thing when you want to strengthen is basically to assess what is existing, and overarching is the IT platform. That is important. Next, please. So another important part is that who is there at the Health and Wellness Center is our community health officer, who is either BSc in nursing or, basically could be a person from the alternative medicine also. And there is a 6-month certificate program in community health which the person is supposed to undergo, along with 5 to 7 days of supplementary training on new health programs, and more emphasis is on new skills and refresher trainings every year. So when one goes for looking at this, one will be evaluating against these backgrounds also. Apart from the basic knowledge, the skill assessment of this community health providers is very important. And I'm very happy to share with you that, the government has already assessed through JPIGO, this 18 states health and wellness centers have also been assessed, and from each state, one health and wellness center has been selected also. And then also we'll be looking at 3 days of training on use of IT application and telehealth, and regular monitoring and training through eco platform. That is important. So overarching becomes our IT platform, which is very, very important, so that people can get connected to the secondary district hospitals. Because when I talk to nowadays, vaccines are in great, I'll say, not only, I'll not say they are in demand, but, we have got a lot of consultation around vaccination and all that. And I've done a lot of, trainings on vaccine hesitancy. And what I realized that particularly now, our community health officers in states of southern states, they are very much in touch with the district hospitals and other hospitals. So IT platform is very strong. So this is one thing which needs to be strengthened as an integral part of health and wellness center, and along with diagnostics, because we cannot do anything without diagnostics. So this is where this is just a map of India which talks about, 18 states, where 8 health and wellness centers were taken in phase 1 and 10 in phase 2. Next, please. So, and what was the focus and scope of assessment of these health and wellness centers was to assess the pace of rollout of health and wellness centers in different states, to identify specific challenges. An assessment should also allow an evaluation of bidirectional impact of health and wellness center rollout and COVID pandemic. So right now when we will be looking at, we will also be looking at the global health security part also. Next, please. So one thing which came out was that each state has been expected to develop a short to medium term roadmap, and the number of health and wellness centers targeted for operationalization by December 2022, along with availability of medicines and diagnostics. Next, please. So, and it is very clear trend of shifting of digital method of indenting and inventory management, which should be there at all health and wellness centers, and use of AB-HWCs system for inventory management, which was very much appreciated by the staff. Now whatever, assessment has been done, the staff is really appreciating the ease of, AB-HWCs system management, because we are giving away with the heavy bulky records and all that. And there has been improved availability of diagnostics and medicines at health and wellness centers, particularly for non-communicable diseases. And then establishment of hub and spoke models for diagnostics are also being set up in some of the states, and which is a must, and gradually smart health and wellness centers should be looking at that. Next, please. So And some of the states basically like Bihar, which we'll be looking at Uttar Pradesh also, that we have to look at the bottlenecks also and reallocation of funds also. How the allocation of funds is smooth or not, that will also be looked at. Next, please. So there still continues to be significant, challenge in implementation of ICT initiatives, and particularly with regard to, hardware, softwares and all that, which will be assessed and rectified through these, and these will be serving as, when FICCI comes into, the whole picture. So, and that means it's a strong private-public partnership. So this will be demonstrated and serve as a role model for other health and wellness centers within the state itself. Next, please. So our objective ultimately will be to provide optimal implementation of all the services along with teleconsultation services, which has been hindered so far by the poor internet infrastructure, along with poor quality video in handheld computers and non-availability of consultants. So that will be our main focus as well. Next, please. So also, so far due to COVID, it's not possible to properly assess the impact of conversion to health and wellness centers in terms of increased footfalls. So that another issue which we will be looking at now is, in terms of, because pandemic may come anytime. So this is where our health and wellness centers have to take into consideration that, how our pandemic preparedness starts from the grassroots level. Next, please. So basically we have to see that holistically the gap analysis will be done, accordingly the rectification will be done, and we will see that in future these health and wellness centers, become the role model for others. And I'm very thankful for all the states who have come forward, basically for, the 30 health and wellness centers in Uttar Pradesh and 10 in Chhattisgarh. So that, and also we will take the advantage of whatever gap analysis has been done now, so as to, look at those gaps and move forward. Thank you so much. Thank you.
Thank you, Dr. Garg. With this, I'll now invite Mr. Karan Singh, the Managing Partner for Bain & Company, the knowledge partner for this initiative. He will do a brief context setting and also moderate today's panel. After he's just opened up the session, we'll request for comments from our chief guest. Over to you, Karan. Great.
Thank you very much. Good morning. Let me just check if this works. Just help me with the... okay, great. It's great to be here. It's been a privilege to have worked on this topic on the ALVL Foundation with Om, Tansi, Dr. Vandana and Dr. Lal. And I'm so glad that we are taking and thinking about scaling this up in 2 other states. And the discussion with the panelists leaves me extremely encouraged of some of the solutions people are going to share today. So this is it's great to be thinking about how do we expand the health and wellness centers and create smart health and wellness centers in India. What I'll do is I'll quickly set the context. I think a lot already has been said, so I'll be pretty quick. I think our chief guest is who we really want to hear from, so I'll try and do this in the next 5-7 minutes. But I think the first point I wanted to make, where do I point this? Is if we think about where we are today, health is an agenda, is top of the agenda for everybody in India. So it's a great opportunity as we are seeing what the accomplishments have been on the vaccination side, on telehealth being a absolute reality. And let me just sit here. Telehealth being a reality, the progress we've made on the National Digital Health Mission and the work we're doing, we see substantial investment going from the private sector. So with health and increased consumer awareness here, I think this is a great opportunity for us to think about expanding primary care. There is a momentous change in terms of digital adoption, as we all are aware. The data on the top is a survey we ran in terms of how do we think about digital health adoption in the metros and the tier 1 and the non-metros. And if you see across areas like telehealth, long-term disease management, records, etc., the expectation of how this will dramatically change. So this is the opportunity for why we are thinking about this as being a smart health wellness centers. This is the time for us to think about adoption of that. I think a lot has already been said, but I think it's momentous with the announcement by the government of the 1.5 lakh health and wellness centers in 2018. The question really is, how do we take this forward? And I think there is a huge opportunity. I can't use your clicker. Where do I point this? But where do I point it? Sorry? I'm going to skip this page. If you just tell me where to point it. Yeah, just stay here for a second. I think there's been a lot of allusion to the importance of NCDs and the concern we all have. If you look at the tsunami of NCDs that we are all quite aware of, and then just the impact of how this is going to, the importance of this from a country basis, I think some of the, on the next page, you'll see the impact of, if you just move to the next page, if you look at the learnings from other geographies in terms of what has really impacted and improved NCDs, the importance of preventive care, primary care is probably the most substantive, and that again is extremely cost effective. So the experience from the developed world shows the importance of why we need to focus on preventive care and early diagnosis. If you look at also the cost point that Sanjeev mentioned earlier on the next page, we see a huge difference by attacking NCDs and the early stages through preventive care, through promotive care, through early diagnosis, and through drugs and change in lifestyle. And the difference of early intervention compared to late intervention is quite substantial. So primary and preventive care, as we all recognize, is a huge opportunity for us to make healthcare a lot more affordable in the health system. On the next page, if you go to the next page, I think in summary, the importance of primary care is quite well known. It is the first point of access. It is where we can address most of the health needs. As we talk about NCDs and as we talk about providing the most amount of outpatient care, it is also very much a key part of addressing and trying to achieve the sustainable development goals in terms of health, healthcare, good health and well-being. And I think an important point is we all recognize not only the high cost of secondary and tertiary care, but how do we reduce the burden on that part of the patient of the value chain. So I think we all recognize the importance of primary care, but there are many challenges. If you go on the next page, these are pretty well known in terms of a lot of the challenges we are today facing in terms of a lack of primary care protocols, lack of a culture in terms of transactional primary care, the technology element so that allows us to scale primary care. The manpower challenges is also pretty well known across paramedics, nurses, and then the manning of the health and wellness centers. And then again, the business models where people are incented to consume more of primary care. So we are all quite aware, and I think today's discussion in the next session will be all about how do we think about opportunities for us to address some of these challenges. On the next page, there was an interesting report by NITI that just came out. It's a bit of an eye chart, but if you look at some of the disparities in terms of how this appears across states, it's quite dramatic. If you look at the yellows on this chart, if you look at the complement of resources, the attendance, the number of drugs available, the diagnostic availability, this is a big issue and a big challenge for all of us. So I think we have a lot of data. I think we have a lot of experience. And I think if you go to the next page, what we'll see is the role for the primary, for the private sector is quite substantial, given today we are a private sector dominated health system. Whether you look at the spend, if you look at the primary care versus the secondary care, there is a lot of expertise that resides within the private sector. So there are multiple opportunities on the last page of how the private sector can truly contribute in a spirit of partnership to helping create smart health and wellness centers on the next page. That I think is the need of the hour. So I will just stop here and just talk about, this is an opportunity for all of us to come together to create a true partnership to truly impact a critical part of healthcare that I think we all recognize is a need of the hour. So looking forward to the panel discussion and the suggestions from the panelists and the audience. But I think we are delighted that Mr. Rajesh Bhushan is with us and to have the support of the government. So with that, I'd love to invite Mr. Rajesh Bhushan to share his thoughts and perspectives and to thank him for supporting this initiative.
Very good morning to all of you. Director General Shri Arun Chawla, Honorary Brigadier Dr. Arvind Lal, Mr. Sanjeev Navangal, Dr. Sunila Garg, Mr. Karan Singh, Ms. Meenakshi Datta Ghosh, Dr. Arun Agarwal, distinguished ladies and gentlemen. Before I talk about the primary health care and the role of the private sector, let me first focus on the bigger picture and try to situate primary health care within that bigger forest, which has trees, which has flora, fauna, and lot of other things. So in the last 2 decades at least, in India, we have faced this huge challenge of dual burden of diseases. On one hand, we have communicable diseases, which has vector-borne diseases, TB, malaria, so on and so forth. On the other hand, we have the non-communicable diseases, which are basically lifestyle diseases. For example, hypertension, diabetes, cancer, so on and so forth. So whenever a public health system has to be designed and has to function, it has to keep in view the fact that it is facing this dual burden of disease. So when we say public health system, it also involves the beneficiaries of the public health system and the people who are supposed to implement or deliver the public health services. So that is one big thematic idea that we must keep in mind while going ahead. As a result of this dual burden, what has happened? What has happened is overcrowding of our secondary and tertiary healthcare facilities. But that overcrowding is not only because of the dual burden of disease, that's one big contributing factor. That overcrowding has happened also because of weaknesses of the primary health system and a historical sort of underfunding of the primary healthcare system. So, what are these 2 big strands that I have so far highlighted before you? On one hand, you have the dual burden of disease. On the other hand, you have overcrowding of your secondary and tertiary healthcare facilities, whether they are in government sector or whether they are in private sector. So if that is the case, what is required? What is required is a fit for purpose primary healthcare system. When I say fit for purpose, although it sounds good, but it must mean something. So what does it mean? Fit for purpose primary health system means a primary health system that provides comprehensive primary health care to realize the goal of universal health coverage. So it was in this context that in 2017 we formulated India's new health policy. And in 2018, in the Union Budget, which a couple of colleagues have referred to, we announced the Ayushman Bharat Health and Wellness Center initiative. So this is not only Health and Wellness Center initiative, as I repeatedly said in the beginning, the bigger picture should never be lost sight of. So the bigger picture is that 2017 health policy said that health is not mere curative health. Health is not what happens inside a hospital. Health is promotive, health is preventive, health is curative, health is not health, it is wellness and well-being. So this was a paradigm shift. So usually these paradigm shifts are difficult to explain to larger group of people. So you need some catchwords. So the catchphrase in this case was Ayushman Bharat, which loosely translated in English would mean long live India. So now Ayushman Bharat rests on 4 pillars. The first pillar is Ayushman Bharat Health and Wellness Centers, which is basically primary health care centric. The second pillar is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana, which is primarily secondary and tertiary healthcare centric, which involves both public and private providers. The third pillar is Ayushman Bharat Digital Mission. Earlier it was known as National Digital Health Mission. Nomenclatures change. So today it is ABDM, Ayushman Bharat Digital Mission. And it sort of creates or aims to create a digital ecosystem for delivery of health services. And the fourth pillar is Ayushman Bharat Pradhan Mantri Health Infrastructure Mission. Why was the fourth pillar needed? Because we realized that there are certain geographies within India which have historically suffered neglect of health infrastructure. So until and unless you address that historical neglect, create infrastructure in those neglected geographies, the overall thrust of Ayushman Bharat cannot be realized. So this is another big strand of health related thinking of the union government that we need to keep in mind. Now, some of our colleagues said that a large part of health is delivered and a large part of health burden is borne by the private sector providers. That is absolutely correct. If we look at the national health accounts of 2018, the 1920 are about to be released. So national health accounts 2018 point out that 57% of the current health expenditure is at the level of private healthcare providers, 57%, which includes private hospitals, which includes private clinics, which also includes neighborhood, husband-wife run kind of health facilities. So 57%. If we look at the NSS estimates, which are of 2017-18, they say that 55% of all hospitalization is in private health facilities. So going ahead, we need to keep this in mind. So private sector is a critical player and must get involved not only, I am repeating, not only in secondary and tertiary healthcare, but also in primary healthcare, which has, historically remained a less glamorous area for the private sector, because that is where the real challenges lie. Even in secondary and tertiary healthcare, where I just said that 55% of overall hospitalization is in private hospitals or health facilities, this is limited to metros and bigger towns. Tier 2 and Tier 3 towns, as you all know, still have huge gaps where private sector can step in, but then you would need a enabling ecosystem, and that enabling ecosystem would come partly from the Union Ministry of Health, partly from Union Ministry of Finance, partly from Union Ministry of Industry and Commerce. So everyone would have to work together. But then you are intelligent people, you are aware of the issues involved. Another point that I wanted to bring to your notice is the involvement of private sector. And now let me come to the primary health care and the challenges associated with primary health care. As you all know that in 2018, the union budget, it was announced that we would have health and wellness center. It was a new concept, and 1,50,000 such centers were supposed to be operationalized by December 2022. As I address you today, we have 1,20,000 such centers already operational across the country. So when we say operational, what does it mean? It means that they would deliver 12 packages of healthcare services. So these packages will relate to reproductive child health, they would relate to NCDs, they would relate to screening for 3 common cancers, oral, cervix and breast. It will relate to screening for hypertension, diabetes. It would also relate to health and wellness sessions in terms of yoga and other physical exercises. It will relate to free distribution of drugs, free availability of specified diagnostics. So this is the entire concept of a functional Ayushman Bharat Health and Wellness Center. Some of our colleagues who spoke before me did refer to the fact that there are supply chain problems in some of the states. Then there are also HR problems in some of the states, and there are problems that are associated with prompt and efficient delivery of these healthcare services through these health and wellness centers. So keeping this in mind, we should look at a partnership between non-government, non-commercial entities as well as various state governments. That's one of the various permutation combinations. Another could be a commercial entity partnering with the state government, because the eventual delivery is done by the various state governments. At the end of the day, health still remains a state subject as far as the Constitution of India goes. Although certain policy interventions are done by the Union Health Ministry, and we are always there to lend a helping hand, supporting hand. But the implementation arms are in the states and the union territories. So what we need to do is utilize forums like this and other such forums to encourage the private sector providers to engage with state governments, to forge partnerships which are long-term and sustainable, and to then add value to whatever is happening in these health and wellness centers. Adding value, I will give you one example of how one adds value, and this is something that adversity taught us. This was in April 2021. While facing the pandemic, we realized that most of the health facilities were either closed or had become exclusively COVID dedicated. So non-COVID essential health services were disrupted across the globe. It's not as if it happened only in India. But India acted proactively, and we evolved a teleconsultation model which was available free of cost since April 2021 till date in collaboration with CDAC, which is another entity of the union government, and that teleconsultation application is known as eSanjeevani. So what does eSanjeevani do? It permits patient to doctor consultation, both audio video. It permits doctor to doctor consultation, and it also permits assisted consultation. This is something which is unique to our country. It may have relevance in, say, other continents also. So why do you need assisted consultation? Suppose I am in a village in Bareilly in Uttar Pradesh and I have fallen sick. I cannot go to my primary health center, which is my first port of call. But the primary health center, even if I am able to go there, would only have a CHO, as Dr. Sunila just told you, community health officer, who's a BSc nursing qualified lady professional, or a Ayush doctor. So what do? I have two options. One, I download that application on my mobile and I find out which are the doctors available for free consultation. Everything is free. That application is free, consultation is free, and then I consult. But I may not be that tech savvy. So then what happens? Then I ask my neighbor or some, good soul in the village if he or she could accompany me to this health and wellness center where the CHO is sitting, but because of COVID is unable to provide any service. And she is linked to a secondary healthcare facility, which could be a Jila Aspatal, or it could be a medical college hospital in the district, or it could now even be a AIIMS, because now we have opened 20 new AIIMS across the country. So these secondary and tertiary facilities to which this primary health care center or health and wellness center is linked would have a specialist doctor. So then I tell this CHO कि मेरे ये लक्षण हैं, these are the symptoms that I am suffering from. The CHO in turn communicates it to the specialist who's on the other end, maybe geographically removed by 100 kilometers or 200 kilometers, and the specialist then says that these are the kind of tests which I need to undergo and these are the medicines that I need to take. So at the end of the day, I have saved time, I have saved money, and I have reduced the burden of accessing health service. Now this whole mechanism needs to be refined. In what manner? Let me give you another concrete example. Suppose I am the specialist sitting on the other end of this call in a district hospital or in, say, AIIMS Rai Bareilly. But I may have scheduled certain surgical procedures for the day. So therefore, a mapping of when I would be available, which days, what time, and what are the various PHCs or health and wellness centers that would be tapping my expertise on, say, Monday, if I am supposed to be available on Monday. That map should not only be with me, but it should also be with that health and wellness center. So that is the area where we are working to further refine this system. My colleagues Amit from UP, who would be joining you virtually, and another colleague from Chhattisgarh, Sanjay, will be able to give you more details on this. Now, the eSanjeevani is the basic application or the mother application, but there could be multiple applications that could ride on this. It is like providing a car and saying that who wants to ride in this car and add value to that ride. So multiple private promoters can come up with their digital applications and can ride on the mother application or the mother digital platform that the ABDM, Ayushman Bharat Digital Mission, provides. For this purpose, within NHA, which is National Health Authority, which is a entity attached to the Union Ministry of Health, we have created a sandbox environment for these young startups or private promoters. They can develop apps, they can use that sandbox facility to see whether their app works, is in harmony with the digital platform or the mother app that we have created. So one concrete example of getting people from private sector, from outside government to collaborate with the government. So going ahead, we need to look at appropriate technology, not necessarily cutting edge technology. We may not require cutting edge technology in this sector of primary health care, but we do require appropriate technology, which may be cost effective. We are, as a nation, known globally for low cost or frugal innovation, जिसको हम बोलचाल की भाषा में जुगाड़ कहते हैं. There is nothing wrong in doing जुगाड़, because the moment I say frugal innovation, everyone says, oh, very good. But I say जुगाड़, because जुगाड़ क्या कर रहे हैं? So, you see, we have certain innate strengths within our government sector as well as private sector, which we must exploit. I have given you just a few examples, because otherwise this could spill over, and I would be eating into others' times. Now, in the end, I would like to say and utilize this platform opportunity that both the union government and the state government are open for such partnerships with private promoters, with non-governmental entities, with the industry, to strengthen the primary health care. That is number one. Number two, for any such engagement to go further, it will be important for states to prepare their baselines of where they are today in terms of performance of their health and wellness centers, where is it that they want to go, the end line, and what is it that the state government and the union government can bring to the table, and what is the differential that they would want the private sector to bring to the table. So that's the second part that should be done. The third part is, I was asking Brigadier Lal when I was sitting with him, there are certain examples in UP, in Uttarakhand, in Rajasthan, where such partnerships have started taking shape. So we must learn from that experience. But to learn from that experience, it will be necessary to disseminate that experience. So please document, what has happened so far in these interventions where private sector or non-governmental sector has been involved. Charities would come into that. So that must be documented and disseminated so that bigger scale replication of that effort can take place across various states. So these were some of the stray thoughts that I wanted to share with you. I thank you once again for giving me this opportunity of sharing my views with you, and for being so patient and listening to me. And I hope today it's a bit of a rush, but I do hope that in future I get an opportunity for a longish interaction where I can hear other participants also. So thank you once again, and I wish you well. Thank you.
Thank you, sir. Karan, over to you.
So I'd love to thank you, Mr. Bhushan. I think it will be great to have Mr. Amit Mohan Prasad, who I believe is waiting for us to share his thoughts, building off what Mr. Bhushan mentioned.
Very good morning to all of you. I hope I am audible. Sorry for not making it physically. Secretary Government of India, Shri Rajesh Bhushan, Mr. Arun Chawla, Dr. Arvind Lal, Mr. Karan Singh, and other dignitaries on the dais, and ladies and gentlemen in the audience. I'm extremely happy and honored to be with you all this morning. Recently, a delegation of FICCI led by Dr. Arvind Lal came to us, and they told us about the efforts that they have made in the state of Uttarakhand about converting health and wellness centers into smart health and wellness centers. And we are in discussion with them for taking up a pilot for 30 health and wellness centers, and it will be finalized after some due deliberations very soon. I must thank FICCI at the outset for this beautiful opportunity. Before I come to the topic of health and wellness centers, I would like to inform you all that this year we have made a provision for a new scheme, budget line, where we will be supporting charities for setting up hospitals in the bordering area of the state, on the borders of Nepal, on the borders of Bihar, on the borders of Chhattisgarh, because these are remote areas and they require healthcare facilities. They're generally neglected areas. So we will be providing, capital grant and also some operational grant to the charities, charitable organization, or large corporates who want to do this through their CSR. So that is one good news that I wanted to share with you. This is an opportunity which you can take up. Now, coming back to today's topic of transforming healthcare through the health and wellness centers. We all know that primary healthcare is extremely important. As Secretary Health was telling, it has been, it has remained underfunded, but extremely important to ensure that there is not undue load on our secondary and tertiary healthcare systems. And if we are able to, as the saying goes, a stitch in time saves 9. So if we are able to cater to a lot of small issues at the primary healthcare level, then these do not blow into bigger things, and then we do not require major interventions. I had the good opportunity of working with Government of India in the Health Ministry for some time, and I did two good things while I was in the Health Ministry. The first was I did my third master's during my service career. That was in population sciences from IIPS Mumbai. So that has given me a lot of insight into public health problems of the state, of the country. And the second good thing that I did was to travel across the country and see sub-centers. I visited almost 25 states and UTs during that time and saw hundreds of sub-centers. And then I came up with two ideas which were not, not accepted at that time. But I'm happy that it is seeing light of the day today in both the areas which I was advocating for at that point of time. I was of the view that the sub-centers, it is high time that the sub-centers should be converted into dispensaries with better roads, better transportation. It was always possible for the people to reach the sub-centers rather than only using that as platform for outreach and utilize that. So at that time, it was thought as an outlandish idea, but I'm happy that in 2018, Government of India finally decided to convert all these into health and wellness centers. And now they will be practically the first port of call for primary health care. Otherwise, we all knew that the health sub-centers were only looked at, some kind of a platform for reproductive and child care, where only you did some immunization or you provided care for the pregnant women. But now the spectrum is much wider, 12 package of services, and it covers almost the entire basic need of the populace which lives in that area. So that is one good thing which has happened, and I am sure health and wellness centers are going to be the bedrock of primary healthcare in the country in the days to come. It is already getting transformed, and it will be bedrock of primary healthcare. The second thing which I had advocated at that point of time was to ensure that the healthcare facilities that we create, that we set up in the public sector are appropriately located. And I had advocated, in fact, when I was Joint Secretary NRHM, then I had brought this proposal also that we should help the states procure appropriate piece of land if it is not available free of cost. It was shot down again as an outlandish idea at that point in time. What happens? We create new infrastructure for the primary health care. We create new sub-centers, but we will construct that on always. It is a convention. It is almost a given fact that these have to be constructed on lands which are available free of cost from the government side. So ultimately what happens that you end up constructing a building 2 kilometers away from the village in the midst of nowhere, where the A&M cannot feel safe and secure staying there in the quarters that we make in the night. And people also find it inaccessible to reach that place to access primary healthcare services. So fortunately, the thing which I could not do then, we have been able to do it in UP now. And we have come up with a government order which defines appropriateness of land parcel for every kind of facility, starting from sub-center up to the district hospital. So a sub-center cannot be more than 100 meters away from the village, from the village abadi, where people are actually staying, living. It cannot be more than 100 meters away. So if that parcel of land is not available free of cost, then we will have other means, and ultimately, if by gift or by exchange also, we cannot get this free piece of land, then we will buy it. And we have already come out with the government order. We have already provided, created a new budget line. We have already provided money for this. So I am hopeful that the primary healthcare facilities, the new primary healthcare facilities that we set up now will be appropriately located so that people are actually able to utilize these. In the private sector, we know that private sector tries to create demand for increasing its bottom line. But in the public sector, you increase the utilization and accountability of a facility by trying to increase demand. It is not the bottom line which motivates the people who are working there. So you have to give an external push. You have to increase the demand for the services provided in that facility, and that will increase the utilization and accountability of the facility. This we have seen when Janani Suraksha Yojana was introduced in the country. We have seen the utilization of government facilities went up dramatically. So, so we have to increase the demand of services, demand for services. The other two things which Government of India is thinking, I would urge Secretary Mr. Rajesh Bhushan to we discuss this, and I would urge that the idea of nurse practitioner should be implemented as soon as possible to improve the primary health care. And that would be really, really good thing. I am happy because my computer had some problem and my phone is running out of battery. So I will have to stop here. I had a lot of other things to share. One thing which I want to tell you is that we have renamed Village Health and Nutrition Day as Chaya VHND, because Chaya is a non-hormonal contraceptive. It is very popular, and to increase the awareness about family planning services, to increase its uptake, we have renamed VHND as Chaya VHND. And finally, I would like to thank you all. I would like to say that, making concepts easier, but when you try to convert them into reality, it is very, very difficult. It is very challenging, daunting, but not impossible. So thank you very much, Vicky, for giving me this opportunity, and thank you all. Thank you very much.
Thank you for joining, Amit, and thank you for your thoughts, Amit, and great to hear what you're doing in UP across multiple dimensions, and how you want to make sure that demand is increased. We look at nurse practitioners, family planning. So we will come back to you, and appreciate all your push here. Would love to shift gears a little bit and get Mr. Mansoor on to share his learnings and share his perspectives from Chhattisgarh. He's also joining us virtually, I believe.
Thank you, respected dignitaries. So I would like to thank Vicky for organizing such a wonderful this event about wellness centers. Chhattisgarh, from the inception of this Ayushman Bharat Health and Wellness Center program, has actually taken up this program to its core, and it has transformed 94% of the centers into health and wellness centers. As far as the state target is concerned, state has actually, we have kept a higher target than what Government of India has given to us. We have decided to take up 6,000 plus wellness centers in our state. And
it is not very clear.
So far
can we try and increase the volume? Can you increase the volume if possible?
Yeah, I'll try. So,
go ahead, Neeraj.
Thank you. Thank you, sir. Basically, Chhattisgarh, the availability of the human resource, specifically which are the central part, because either it is hilly, the southern part of Chhattisgarh is affected area, and the northern part is tribal again. So,
yeah, absolutely. Neeraj, can you hear us? Neeraj, can you hear us?
Yes,
We are not being able to hear you very well.
Yeah, I can hear you, sir. I was just.
We are not being able to hear you very well.
I think I have again joined, sir. Is it audible now?
Yeah, a little bit better. You want to try again?
Okay.
Go ahead, please go ahead.
So what I was talking about is, yeah, Chhattisgarh is primarily is mostly a rural and tribal state where we lack proper healthcare services in the southern and northern part of Chhattisgarh, which is mostly hilly and tribal. LW affected part of Chhattisgarh is there. So the places like Raipur,
Should we just, do you want, Neeraj, I'm assuming you can't hear us also. Should we come back to you, Neeraj, and we can maybe...
Okay, sir. Okay.
I think you may be in a bad cell site or... Can you hear us?
Yeah, I can hear you, sir. Am I audible right now?
Yeah, you're audible right now. You're coming in and out. So you want to try once again and then
So
if not...
I will be brief, sir. It's very... Yeah. I will be very brief, sir, since the network is so poor, I don't know. So
Sure,
I wanted to tell you is that Health and Wellness Center in state of Chhattisgarh, we are actually doing good work, and we have been, the state of Chhattisgarh have been awarded lot of under this initiative. Like Chhattisgarh has always been in the top 5 states for making health and wellness centers operational continuously over the past 5 years. And apart from that, we not only focus on health and wellness centers, but beyond that, we are trying to link the health and wellness center with Mukhyamantri Hart Bazar Clinic Yojana, the state's flagship scheme, where we basically run the mobile medical units, heart bazaar. There are small heart bazaars which are organized in the tribal areas. People flock in mass. They don't have because even if the standard population size of a sub-health center in Chhattisgarh is lesser in tribal and these areas, but the people, they have to travel a lot of, maybe sometimes 7 to 8 kilometers to go to a nearest health and wellness center and sub-centers. So in order to bridge this gap, we have come up with a solution called Mukhyamantri Hart Bazar Clinic Yojana, where this, it is sort of a continuum of care. We run the clinics, we do all sorts of NCD clinics and diagnostics in these Hart Bazar clinics, and then we link in health and wellness centers. Further, more and more, after that, being the CEO of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana in Chhattisgarh, I also look up that program and try to get this screened population of health and wellness center, and based upon their ABA IDs and also based upon their Ayushman cards, the patients are tracked, and then if needed, the patients are admitted in the primary health center, the community health centers, the higher tertiary care centers. So we sort of track these patients who first come to us either in health and wellness center or in Mukhyamantri Hart Bazar Clinic Yojana. This the success of this program is actually basically we have made a chain. The patient doesn't lose the track in a state. So that is one of the important aspect of which was not there, and it has come into the picture only because of the Ayushman Bharat Health and Wellness Center. In the last by Honorable Prime Minister, when he had spoken about the continuum of care of Ayushman Bharat HWCs and the Ayushman PMJY. So yes, that is the most important challenge which I see as far as Chhattisgarh is concerned, because we have a small piece of tertiary care services in the central. So that continuum of care is very important for us. We then pull and integrate the sources of the 104 Arogya helpline and the telemedicine services. And currently, the platform of Ayushman Bharat Digital Mission. Now, once we actually, we have almost integrated 95% of our government public healthcare facilities into the Ayushman Bharat Digital Mission portal. And then once we leave, there are roughly 1.5 crore ABA IDs we'll be in a position to generate very soon. So people, the healthcare professionals, the public in general, and the health facilities, all are in sync with Ayushman Bharat Health and Wellness Centers, Ayushman Bharat Digital Mission, and Ayushman Bharat PMJY. So all these, what I believe is all these three programs are actually interlinked. And when the two integration happens, it will be one of the ideal integrated continuum of care which we envisage that should take place in the state of Chhattisgarh. What the further I would like to say that we are actually, although the concept note which was shared with me by the organization of this organizer of the workshop, what I get to know is that the Chhattisgarh lacks HR, definitely. But over the past 2 to 3 years, we have recruited medical officers. Now the vacancy of the medical officer by the end of this month will be not less than 20% or 10%. And likewise, specialists, we are also recruiting specialists, although we don't provide the specialist healthcare services in HWCs. But we have rural medical assistants who are the excellent mid-level healthcare providers. We are having CHOs, community health officers. Now we are also posting medical officers in all the PHCs. So time has come that these health and wellness centers would be in true sense would be giving the actual healthcare services in the remotest part of Chhattisgarh. Since my network is very poor, and I thank Fiki for this giving me this opportunity. Thank you very much. Thank you all.
Thank you very much, Neeraj. It sounds like you're doing a lot in Chhattisgarh on NCD screening, on what you mentioned on tracking, on the linkage with the continuum of care, with all of Ayushman Bharat, all the pillars that Mr. Bhushan talked about, and also addressing the very important issue on manning. So that's great to hear. We will be in touch with you as we think about the experiments in Chhattisgarh. But thank you very much for joining. I just wanted to shift gear. We are running out of time, but we've got a great panel. I think the need, the challenge, and the opportunities are pretty clear. It's been well established, and also the importance of such a transformative partnership with the private and the public sector. But let's shift gears and maybe focus more on some of the learnings from experiments, and then what does it mean for solution themes from the great panelists that we have here. So we'll have Dr. Lal, and maybe we'll keep this quite brief for all the four panelists. Dr. Lal will share the first-hand experience from Uttarakhand on the smart health and wellness centers. It's great to have Dr. Azim here. It's inspirational what UpHealth has done in terms of digital clinics. So he'll talk a little bit about the digital opportunity and how do we scale using the digital medium. We have Dr. Raina, very inspirational of all the community health initiatives in Kangra. So we'll hear from Dr. Raina on that topic. And then Mr. Vazirani is joining us virtually. We'll talk about what Rajesh Bhushan mentioned is fit for purpose or appropriate medtech to make sure it's actually low cost or affordable healthcare. So great set of panelists, but just in the interest of time, I'll also maybe, to make this a little bit more interactive, maybe if people want to ask questions along the way, just feel free to put up your hand so we can have more of a dialogue, given we will run out of time. So with that, Dr. Lal, if I can turn it over to you just to share your experiences in Uttarakhand.
Thank you, Karan. May I have the first slide, please? So with our health sector experience of over 4 decades, when Vandana and I instituted the ALVL Foundation to work in the primary healthcare space, and I must add here that we also have 2 other members of our foundation, Dr. Om Manchanda, who is sitting right here, our Managing Director of Dr. Lal Path Labs, and Mr. Karan Singh himself, and Tansi Naik. Tansi, can you stand for a moment? She's our Vice President of the Foundation. There she is. Okay. So we had no doubt that when it comes to providing primary care to 1.3 billion people across the country, such a scale can be achieved only by working with the government and not alone. So that is why we decided to channelize our resources towards supplementing the government's ongoing efforts in HWCs. We started with Almora district in Uttarakhand because we have deep spiritual ties to the place and have been involved in various health initiatives in the area, including running a charitable hospital for eye surgeries. Shroff Eye Hospital is there in my hospital, and 2 Ayurvedic hospitals also. Slide number 2, please. We have signed 2 MOUs, number 1 with NHM Uttarakhand for 7 PHC HWCs, including 30 plus sub-health HWCs. A PHC HWC is a primary health center upgraded to the Health Wellness Center headed by an MBBS doctor called the medical officer or MO. Whereas the SHC HWC is a sub-health center upgraded to Health and Wellness Center, as alluded by Dr. Sunila Garg, and the Secretary Health also said the same thing, headed by a community health officer CHO who is usually either a BSc nurse or an Ayush doctor. Second MOU which we signed was with the Ministry of Ayush, Government of India, and Department of Ayurvedic and Unani Services, Government of Uttarakhand, for 3 Ayush HWCs. Our aim was to partner with the government to develop the selected HWCs as demonstration models as smart HWCs to deliver comprehensive primary health care. During our site visits and consultations with the stakeholders, we observed that while a lot of effort has been put into upgrading the existing primary health facilities to HWCs, some gaps still existed in areas like, third slide please, human resources. So 50% of the human resource positions are still vacant in 5 out of 10 HWCs. At the PHC level, nursing, lab technicians, and multipurpose health workers positions are also vacant. Deployment of community health officers for sub or SHCs, as we have just said, was delayed due to the COVID, but now CHO positions have been filled after ALBL Foundation raised this with the NHM Uttarakhand. Those sanctioned specialist doctors are still not available in community health centers or CHCs, adversely impacting specialist care for patients who need to be referred from the HWCs. The second part is financing, and we noticed that there were inordinate delays in disbursement of funds from state to the district level. The medical officers shared that funds are released to them, say on the 1st of March, and withdrawn back in 15 days to close the books by 31st March. District CMOs and MOs of HWCs do not have the authority to utilize funds as per their ground level requirements. Therefore, it is our recommendation that utilization of funds needs to be decentralized up to an optimal limit. In the army, we call it local purchase. Number 3, expanded services delivery. Even the centers that have now been upgraded as HWCs still continue to provide the same services that were being provided earlier. No significant expansion or addition of new services has taken place, and we also observed low level of awareness and training on expanded services amongst the existing staff other than the CHOs. Next is the continuum of care. We observed weak referral linkages between the population and HWCs, lack of patient transfer and ambulance services, and ideally around-the-clock telemedicine at HWC is also required. Referral linkages for specialist care are non-existent. GPs are available at PHC HWC level and through e-Sanjeevani, but no specialist doctors are available even by telemedicine. Slide number 4, please. The essential drugs. Due to centralized procurements, medical officers don't have much authority over what medicines are available at the HWCs. Centralized procurements also cause delays in restocking in case of short supply. Indenting, stock keeping, and dispensation of drugs is being done manually at all HWCs, which needs now to be digitized. Next thing is essential diagnostics. We found that only 2 out of the 10 HWCs had partially operational labs. Even these 2 labs were performing only 20 out of 40 tests on the menu, recommended by the WHO and endorsed by the ICMR as a National Essential Diagnostic List, or NEDL, and majority of tests available were on rapid diagnostic kits or on the card test format. No referral services for diagnostics existed in the rest of the 8 HWCs or the SHC HWCs. As per the recently released report of the Government Commission third-party assessment of HWCs across 18 states, on an average, only 12 tests out of 40 on the menu are being done at the PHC HWCs assessed. So Uttarakhand was a shade better when we reached there. They were at least doing 20 out of 40. Then is the digital and the IT services. Almora being a hill district, the penetration of fixed line or wired internet is very low. Broadband internet connectivity is available only in 2 HWCs. Rest of the HWCs still rely on wireless mobile internet with poor connectivity, what you call dongle. This is a strong deterrent to deployment of any effective digital health solution. IT equipments like computers, tablets, printers were missing or dysfunctional in 8 out of the 10 HWCs. No electronic health records or lab information system, management system or LIMS, or any IT-based records were being used. Infrastructure. There was non-availability of potable water, which was observed in 2 HWCs, and the HWCs still use deep burial pits or incineration or biomedical waste management. Therefore, BMD management needs to be implemented forthwith. Next slide, please. After the detailed gap analysis and discussion with the state, district, and HWC officials, 5 priority areas were identified where ALVL Foundation could contribute to uplifting the existing HWCs to smart HWCs. The first one was provision of essential diagnostic services in line with the National Essential Diagnostic List published by ICMR in 2019 and Free Diagnostics Initiative. The second was strengthening referral services via telemedicine for specialist consultations. We started with 3 basic specialties: pediatrics, gynecology, and orthopedics. Third was developing a community-driven health and wellness model to engage more actively with the community through the community health workers, CHOs, ANMs, ASHAs, as well as local volunteers to encourage the population to utilize HWC services. The fourth was capacity building of healthcare workforce on the new services being added in the smart HWCs, for example, sample collection for diagnostics using point-of-care services, screening for NCDs, facilitating teleconsultations, and maintaining digital records. The fifth was leveraging digital health technologies to make quality primary health services more efficient, accessible, and affordable. In the interest of time, I will not get into the details of each of these interventions, but I think it is prudent to at least share how an effective hub and spoke model for essential diagnostic services has been a huge success in these HWCs. Slide number 6, please. Okay. I shared with you that initially 2 out of the 10 HWCs, that is at Tadikhet and Hawalbagh HWCs, had a semi-operational lab. The labs were manned by 1 lab technician each, with very limited lab instruments present. Only 20 out of 40 essential tests that could be performed on site were being done at these labs. In the absence of any lab information management system, all records and results were being managed manually on paper. Slide 7, please. Keeping this in mind, ALVL Foundation upgraded the 2 partially operational labs into fully operational hub labs at Tadikhet and Hawalbagh HWCs and linked the remaining HWCs as spokes by adding manpower, that is 2 lab technicians and 2 courier executives who transported samples from spokes to the hub. Upgraded equipment to include hematology and biochemistry analyzers, microscope, as well as other basic lab instruments like centrifuge, incubators, and introduction of vacuitainers for sample collection, etc. And I must add of the help given to us by Mr. Suresh Vazirani's Trans Asia company. Their hematology analyzers and biochemistry analyzers we used. This helped in expanding the test menu from 20 to 40 tests, including kidney function tests, liver function tests, lipid profiles, and others, in line with the National Essential Diagnostic List. We also digitized the entire lab operations with IT equipment and LIMS. And with this cloud-based solution, reports are now uploaded from the hub lab and assessed by the respective spoke HWCs. Thus, we were able to more than double the tests performed to 10,000 plus tests at these hub labs in last 1 year. This number would have been much higher, but for the fact that the second hub lab at Hawalbagh was commissioned only 6 months later. This model is operating successfully in Almora in a difficult terrain with limited internet connectivity and challenges of extreme weather, especially heavy rains and harsh winters. Therefore, I am confident that a similar model can also be effectively implemented in HWCs in any part of the country. And my last slide, please. Lastly, I would like to highlight a few points on the impact of this initiative on the ground. The first one was overall increase in footfall and utilization of the HWCs. Earlier, around 50% of patients availed services, and that too only for maternal and child health, MCH, but now the proportion of patients availing care for NCDs, specialist consultation, lab tests has increased appreciably to above 60%. Second, reduction of out-of-pocket expenditures, what we call OOPE, for the people who avail services at the HWCs. Number one, for patients who utilize diagnostics and specialist teleconsultation services at the HWC, the cost saving has been appreciable at approximately 450 rupees per patient for diagnostics. Secondly, approximately 700 rupees per patient for specialist teleconsultation, which included transportation to another town, doctor's fee, and cost of medicines. This cost is also being borne by our foundation. Thus, the foundation has spent approximately 40 lakhs in the last 1 year. The confidence and motivation amongst HWC staff, including doctors, ANMs, lab technicians, has significantly increased with the intervention of ALVL Foundation. Thank you very much.
Dr. Lal, just one follow-up. What would be, I mean, you've called out the gaps, it is substantial. You've talked about the aspiration and how the model works. What would be the ask for the government?
So the ask of the government is that just implement what they themselves have written. They have done the legwork is tremendous. The infrastructure which they have created, of course, I'm not talking about what is missing inside, is very, very appreciable. And these gaps are the ones, except for the one extra technician and the field courier workers, everything else is already written there. We just have to request the government that please, come up with the HR solutions. The second thing is, which everybody has said so, and it's Mr. Bhushan also, that the money was always a problem. But when we reached there, they said that we have enough money. The only problem was of disbursement. So all that has to be made, as they said, increasing the tooth-to-tail ratio. It should be available on the ground to the CMOs who apparently have no hand in ordering. And the final thing I had already said about the drugs. Specialist consultation also from for specialists is also not available.
Thank you, Dr. Lal. Moving on to Dr. Azim, can you hear us, Dr. Azim? I know you're joining virtually.
Yeah, thank you, Karan. I'm
Wonderful.
Here.
Would love to hear more about UpHealth. It was inspirational to hear that you're touching the lives of 2.4 million people and the 850 digital clinics that you described. So if you can just explain a little bit more to, on the model and the impact you're having, and then more importantly, the role of digital health in primary care, that would be wonderful.
Thank you so much, Karan. Thanks a lot. So I will share 2-3 slides to share our experience. But prior to that, let me just preface what I have to say by 3-4 points. One is what people sometimes do not realize, that the total spend on primary care is actually more than the secondary and tertiary care, because while at each episode the cost is lower, the number of episodes that at an average there is hospitalization compared to hospitalization, which is 5% in India, it is 2.2 per person per year in this country, and it is global average is around 5 to 6 times a year. So it is something which consumes over a period of time the maximum amount of money which is spent. Second point I would like to make is that somewhere in the discussions it seems to come across that digital health is a substitute where there are gaps in provisioning of services or improvement. I want to make a short point here that digital health is not a substitute. It is essential in a world where you have 7.7 billion people now. 7 billion people cannot be catered to by the older manual forms. So it is inevitable. Third thing I want to make is that poor technology will always give poor results. You cannot have something as a substitute for solving the biggest problems of humanity. You need the highest level of technology, and that is, technology is only good if it is able to bring a huge amount of productive difference in the work that you're doing. The poor need rich technology. By rich, I mean how sophisticated and how much impact can it have in actual delivery. So you need to really focus on that. The third thing is that I want to focus on is that it is not just the cost, the availability, but it is the entire system of healthcare delivery which is transforming. So let me come very quickly in because we are short of time. Just go back to the earlier slide, please. So I just give you an example, and I'm trying to keep it short to only 3 slides. One is it took us almost 6-7 years to create this model of how primary care was more difficult. We already had set up hospitals and protocolized them, but digital health we used, and it took us 6-7 years to create this. We came out with our first artificial intelligence-based clinical decision support system in 2013. But the primary healthcare model took more years to get on the ground, starting with 2016. So today we have over 800 digital dispensaries in various parts of the country. These are one single hub in a single roof, everything from consultation with specialists or general doctors, remote examination, including laryngoscopy, otoscopy, digital thermometers, digital stethoscopes, fetal Dopplers for children, for mothers. Almost all investigations which are required, and we can add more. We do about at an average around 42 the kinds of investigations, liver function test, kidney function test, everything within that same the terminal which you are seeing in that photograph, which is a lab and a clinic rolled into one. And medication in places, in some of the places it is automated through dispensers. In others it is done manually, but system controls everything in the manual process. It can do antenatal examinations, and let's come to the next one, 2 more versions of the same. The second one is a version which we evolved during the pandemic, which is a prefabricated container clinic, which has separation between the nurse and the doctor and ultraviolet sterilization. This is what got UN Innovation Award in 2020. And it can be installed in about 8 hours time and start off with everything the same, clinic, lab, as well as a pharmacy all rolled into one. So you don't have to travel anywhere. You don't have to send tests and collection centers. The whole, in our digital dispensaries, everything what a primary care needs gets done within 30 minutes. Then there is a larger version, which is a primary health center, electronic primary health center, which also has minor hospitalization, labor, normal deliveries with oversight by a gynecologist. So it has 6 beds in one module, and you need 12 beds. You can actually combine 2 modules. Third, come to the next slide, please. So we do today 2 lakh consults on a monthly basis, which is about more than 2 million annual run rate. And by the end of 12 months, it should be about 8 to 10 million on an annual basis. And so we should be able to reach about 10 million or so. We have been able to bring, and we are spread from the east to the west of the country, and some things in the south also now. And we have been able to bring the cost down to, for an entire primary healthcare, comprehensive care, including consultation, examination, investigation, and medication, to about 215 rupees. This includes tests, this includes investigations. This is half the cost of what it costs the government to deliver, and 1/4 of the cost which it costs the private sector to. And it enables complete primary care to be delivered in 30 minutes. It seamlessly links to hospitals for referral networks. The analytics are available on a real-time basis. Nothing needs to be uploaded, because everything, including the stethoscope, is all digitally recorded. And we have been able to bring it to the poor. More than 80% of our patients are poor. One of our organizations, the British government, which had put in some money in us in the year 2013, got an independent assessment of the outcomes done. This is a brief from those, that more than 80% of the patients who were served were poor. The service quality response from patients was 63% to 99% in the services. Accessibility, 94% of patients found that this was very easily accessible, and patient satisfaction was above 93%. We went from, in 2016, from 700 consults in a year to 2 million consults in a period of 4-5 years. And this year we should have a 4x jump again. So I don't want to take much time, because other people also need time to speak. We think, I'll reiterate my major points, digital health is not a substitute. You cannot live with it. And every healthcare organization, public or private, will have to transform itself to be able to cater to the complexities of today's age. Second is, we need to focus on technologies which will be able to serve everything. Instead of pilots, we should start thinking systemically how to change the entire environment and transform ourselves. India has an opportunity of jumping the technology ladder because of the gaps that we have. This is a strength for us. So I believe that we will see a lot of transformation in the next 10 years, and everybody's working for it, and everybody's solution has a value. And we all need to find common ground how to transform what is one of the essential needs, because healthcare is not a choice. It is a basic human right. You can't live without healthcare. Thank you so much.
Dr. Azim, extremely impressive and extremely innovative. Just one question. What is your challenge to scaling this model?
See, I think we have covered areas from Nabrangpur, where there was not even 2G connectivity, so putting up our own towers to ensure there are power issues where you need to put up solar panels. We are scaling today to Philippines and Africa. I'm based out of Dubai to help scale internationally right now. I think the largest problem is simply the attitude to change, and that is inevitable, because change is something which nobody is comfortable with. And the two things which are important is, one is the health departments have an existing system in the government, and it is natural for them to continue to do the fun things that they are doing. And what I think we all need to understand is that the world has immeasurably changed. The demands of consumers, our people, our citizens are far higher, and we all need to make an effort to change. So I don't think there is a technological, operational, financial issue which stops us. It's more of changing our views to what is in the future inevitable. How do you grasp it today rather than react? So as somebody said in the beginning, we need to be proactive to design the future than to set and let other people decide the agenda and then only respond to it.
Thank you. Thanks for the leadership here. Just to shift gears, we are running out of time. Dr. Raina, can you hear us?
Yeah, loud and clear.
Wonderful. And so would love to have you share your experiences in Kangra on community healthcare, what you're doing on NCDs. And I think you're also a big fan of the hub and spoke model. If you can just touch on that briefly.
Sure. Right. Can I share my screen? I have a few slides to share this. Is it visible?
We can see it.
Oh, yeah, fine. So I straight away move to my next slide. Are the slides moving? Fine. So this is something that we have learned over a period of time. And this is not just my learning, it's the learning that we have received at Organized Medicine Academic Guild, as well as some learning that has come to me directly as part of identifying the role of primary care in the total gamut of healthcare delivery. Won't talk of it in detail because we don't have time to permit that.
Dr. Rana, just 1 minute. Can you just put this in projection mode? We can't, slideshow mode.
Is it fine now?
Just wait a minute. Can you just project it fully?
Yes, I have done it.
We're still seeing the left-hand side. At the bottom, if you can just hit the slide, the full screen.
Just do it again.
You can try again.
This is the full screen. Is it fine now?
We're still seeing the PowerPoint.
Okay. Can I do it one thing? You have my slides.
At the bottom, if you hit the slideshow mode.
I'm doing exactly that.
Achha. TK, let's keep going just in the interest of time. Yeah, this is much better.
Okay.
This is
fine.
good. Thank you.
But the slides are not moving now.
Yeah, this is
they are
fine.
moving.
Thank
Fine.
you. Yeah.
So the first slide was just what we have learned at Organized Medicine Academic Guild and what has been my personal learning as far as the role of primary care in this entire healthcare system is concerned. But on personal footings, what we have realized over a period of time, probably in the last 1 or 2 years, when we are trying to see how exactly these national programs are working out in the difficult to reach areas of Himachal Pradesh, we realize that what exactly is missing in the primary care across the country. Next slide, please. And this is the comprehensive primary health care, continuum, promotive, preventive, rehabilitative, and curative care that has come up from the government itself. It has talked about the key elements of health and wellness centers and the delivery of comprehensive primary health care. Next, please. So this was the critical slide that I wanted to talk about. So my learnings have been that, from my understanding has been this, that is it possible to deliver comprehensive primary health care without a primary care practitioner? I don't think so. We still will need the primary care practitioner at the center of delivery of primary health care. But are we willing to recruit them? I'm not very sure about that. We may have issues with regard to recruitment of all primary care practitioners across the country. And at this point in time, our understanding of health and wellness centers that have come to us is mostly provider or management based or service based, and they are not truly patient centric. That is why my concerns are. Because treatment will always remain critical to the patient. For a patient, if you are offering him treatment, you are successful. If you are not able to offer him treatment, then your chances of delivering comprehensive primary health care are not there. Are community health officers able to do so? I'm not very sure about that again, because their training is not at the optimum level to be able to provide treatment to the expected outcomes that we are expecting from our health and wellness centers. Health and healthcare, as this pandemic has shown us over a period of time, is a complex science, and it's not just one-to-one science that we see in other fields of science. Health is more complex. You have the patient's involvement, you have the provider's involvement, and there are a host of factors that literally dictate how exactly health transforms. I was just looking at this NQS, which is a National Health System Research Center developed National Quality Assessment Framework for these health and wellness centers, and if you look at all of them, whether there is care in pregnancy and childbirth, neonatal and infant health services, childhood and adolescent health services, family planning, management of communicable diseases. I'm not sure to what extent a community health officer without a medical officer will be able to deliver these to the optimum. So that's something that I'm not very sure about. So, but these are the problems that we see. Do we have a solution for that? Next, please. So this is what I think is the possible solution. And as was pointed out by Karan before me, this is the hub and spoke model wherein I'm very much interested in. We need to leverage the system through time and geography, dynamic hub and spoke using PCT-based facility as a hub. So this is the future as far as health and wellness centers are concerned. If we want our health and wellness centers to develop and deliver to the optimum, we need to utilize them and utilize them in this mode, wherein a PCP primary care practitioner is at the hub of it, as at the focus of it, and around him, these health and wellness centers can work through these community health officers. Probably what Dr. Lal has already pointed out, the success of each of these models depends upon how exactly do we leverage the existing structures, how exactly do we leverage the role of a primary care practitioner who's already based there at the settings. Next, please. This is the role of stakeholders and low-hanging fruit. This is something that we need to talk about. What exactly each of the organizations which is a part of this partnership will do. So probably FICCI and other partners can provide us services in terms of medicine, point of care diagnostics, telehealth, management, including management of national health programs, because we don't have those managerial capabilities as far as resources are concerned to deliver on these issues. But wherein OMAG can pitch in, what is the role of OMAG in this partnership? So OMAG can help capacity building to help expand services. If you look at the gamut of services that health and wellness centers are planning to deliver, for example, eye care, ENT care, mental health. So these services are not possible unless and until we build the capacity of existing sectors. So here in OMAG, they come in because it's a confederate of 15 associations, wherein you have all types of physicians. You have the physicians, you have the surgeons, you have the pediatricians, so they can all help build this capacity. Second is evidence-based guidelines and protocols, screening for risk prevention and control, including epidemic science. So over a period of time, we have realized that we have to use some screening protocols in these health and wellness centers. We need very easy, appropriately adjusted technologies, techniques to use these screening tools. And that, again, OMAG comes in because it has the capacity to provide us with these evidence-based guidelines and protocols. And work on dynamicity. As has already been pointed out, we need to identify the geographical difficulties. We need to identify the resource crunch that is there with each location wherein these health and wellness centers are established, and try to modify them, try to leverage these things and establish a connect with existing structures through this dynamicity which is there in these systems. Building and testing of a continuum of care and community mobilization model. This is something that I have seen over a period of time, that we see primary care in isolation. Again, like tertiary care, we have seen tertiary care in isolation for a long period of time. At this point in time, we are again seeing primary care in isolation. We need to see primary care, secondary care, and tertiary care all aligned together in a continuum of care model. And for that, we need to identify models, and OMAG can always pitch in and develop and test these models over a period of time. Next, please. So what do we actually want? What exactly should be the framework for future framework for all of us in primary care? What should be the delivery points as far as primary care is concerned? I talk about two only. One is we need an informed, activated patient, and for that we need to mobilize the community, for which these community health officers may be extremely in an extreme good position to inform and activate the patient. But we also need a prepared, proactive practice team. We need a clinician, we need a primary care physician at the center of it, who's able to take care of this informed, activated patient. Because if there is no connect between the two, we are again hitting the rock bottom. We don't have those delivery of comprehensive primary health care in place then. So this is the chronic care model we talk of, wherein both of these, the patient as well as the provider, are both in sync and do have a connection with each other so that this delivery is possible. Next, please. And these are some of the timelines that I have thought of if we are trying to implement this hub and spoke model. So what I suggest is that we use this 3-step wedge design to test our hub and spoke model across states, as has already been envisaged by FICCI and others. And within that, as our secretary was already pointing to us, within that hub and spoke model, we need to put in a few things in place. One is a baseline assessment which can be done at the beginning of implementation itself. And then we can also have those outcomes and indicators defined, that once we put in place this hub and spoke model, what will be our outcomes, how exactly will we measure our success or failures, which will be tested by our analysis at the end. So probably this is something that we can put across to this partnership as well in future, once we start rolling out this hub and spoke model for upgradation of health and wellness centers. Thank you. This is probably my last slide, and that's all I have from my side.
Thank you, Dr. Rana. Great to hear about both the hub and spoke model and the chronic care model, and I think we've all in violent agreement on the need for partnerships here. But thank you for joining. I know we're running quite late. Last but not the least, we have Dr. Vazirani with us, and I think we've not talked about technology or medtech, and it'll be great to get your perspectives on, what does fit for purpose or appropriate medtech mean, and the innovation agenda here. I think multiple people have referred to we don't want poor technology, but we need fit for purpose technology. So if you can just share your thoughts, Mr. Vazirani, that will be wonderful.
Thank you, Karan. I'm conscious about the time, and so I'll be very brief. And also the fact that all the speakers here are very aware of the scene, very aware of the need, the primary health care, especially the insights that we got from Shri Rajesh Bhushan ji, Shri Amit Mohan ji, Dr. Lal, and others. So I don't want to repeat all that has been said, because this is a very learned audience, very learned people who know about the subject. However, as Karan, you mentioned, that I would just highlight on one point about the technology. In a large country like India, we must leverage technology. Without technology, whatever we do will not have the impact that we need. So this is where TransAsia has been specializing. TransAsia's focus has been on technology, and I believe that with technology, the HWCs can really help India become healthy and happy country. Why technology? Because TransAsia has been associated with setting up more than, I would say, 3,000 HWCs across India. And with the smart HWCs that Dr. Lal and Vandana Lal have set up in Uttaranchal. If you see them, there's a distinct difference between the two, between an average HWC and the smart HWC that Dr. Lal introduced. The main difference is two. One is, of course, the technology in terms of connectivity, proper connectivity, database, cloud connection. But more than that is the emphasis on the diagnostics. We all know that 70–80% of the clinical decisions are entirely based on the diagnostic reports. Hence, if you expect the HWCs to be effective and really provide the treatment, it cannot be done without proper diagnostics. And this is one I feel that all those who are planning, thinking about setting up the HWCs become aware that at the core of every HWC has to be the diagnostic facilities. And as I mentioned, that fortunately TransAsia, as being India's largest diagnostic company, we have set up several thousand labs in the HWCs across India. Though I'm not sure how many are properly utilized, how many are effectively utilized, that remains a question mark, because as Dr. Lal mentioned, that most of HWCs don't get the money when they need. They don't get money to buy reagents. I would say 80% of them don't have trained lab technicians to do that. So these are the operational issues that need to be, but even in the planning stage, I believe that just the diagnostics can help not only prevent disease, but also early diagnosis can help cure the disease at a much lesser cost than when it becomes a full-blown disease. So with that, I will urge again that in any planning, the diagnostics has to be at the base core of it, and every treatment should come out of that. Otherwise, it becomes just a clinic to dish out kerosene just to check the blood pressure, but nothing significant, medical treatment can be done without adequate diagnostics. And TransAsia also has developed the He provided laboratory information systems connected with a cloud-based database so that it has the potential for any state government to monitor the disease burden or any change in essential health parameters across every HWC, across every district, so that if they see any change, significant change in any disease parameter, the government can proactively come and do something about it instead of waiting for the newspapers to tell us what disease has broken where. Through that technology, the government can proactively monitor the health of every community across the country and take preventive and quick action to go and provide the relief. So with that, I will end here. Thank you very much for giving this opportunity. And as I mentioned, that Transasia remains committed to making India healthy and happy.
That's great. That's great to hear. Thank you. Just watchful of the time, we have probably another 2-3 minutes left. So any questions from the audience? It's been a very, it'll be good to get any reactions, and then we'll, yeah.
Declaration. So are we still wedded with the basics concepts that Alma Ata Declaration took into consideration, or have we departed? Have we expanded the definition of primary health care? Number one question. Question number two is that one of the declaration was that people have the right and duty to participate individually and collectively in the planning and implementation of healthcare. What exactly is the role of community? How the community gets involved? What efforts are being made to involve the community? Is primary healthcare based on self-reliance and self-determination? These are some basic questions I have.
Thank you. It's a very nice and very practical question. And I myself pointed out in the beginning only, we brought out this concept in 1978 in Alma Ata. But then, we had a lot of barriers and challenges towards expanding our primary health care. If you will see the whole thing in the new national health policy, we have relied on the, complete picture or health profile of the community, because it is not possible to reach for every person to the tertiary level health care. So I'll be brief at this point. So it is, 12 range of services which you are aware of, along with, that technology and digitalization of not only, our healthcare records, but also, provider interaction, where Dr. Rena also pointed out just now, and Dr. Lal has stressed on the diagnostics part. So that's where we need to provide a holistic thing so that people, or the person who is sitting at, or the lady who is there at last mile in Bihar, Uttar Pradesh, or anybody who is sitting in Northeast is able to access the services, and not only the services in the physical format but also in virtual format. So that is important. So it has got 3 components which was pointed out at the primary level, secondary and tertiary, where we get linked to our digital health portal and also PMJY. So in short, this is my answer, but important is that we are now bringing out a lot of new initiatives also, like universal midwifery program. Even the tertiary level hospitals are making use of that. So this is where we have not deviated from the accessibility of care from Alma Ata model. Even Bhor committee suggested that is where it is. So, but then overall, we are being more comprehensive, we are being, more referral oriented also, and we are looking towards the fact that nobody is deprived of the essential care which he or she needs to, looking into, taking into consideration our vast population. Everybody, health is a basic fundamental right. Thank you.
I think we can take probably one or two more questions, and then we'll get some concluding remarks. Yeah.
Sir, this is not a question, I think.
Can you identify just
sure. So I'm Prashant Mishra, and I'm the MD for British Medical Journal Publishing Group in India and South Asia. I mean, it's a excellent session, especially, listening to all of you. So it's basically an offer, not a question directly. As BMJ, we do a lot of work in the primary care settings. We do it on a global scale, and we've been doing it here in India as well, especially regarding the work that Dr. Lal mentioned about Uttarakhand. We've come up with some very good point of care clinical decision support tools that I believe could be very, very empowering for the manpower who man those, health centers. So in very brief, would love to have discussion, dialogue with the relevant stakeholders where we could play our role. Thank you so much.
Excellent. I think Tansi, this is a great follow-up for you. Thank you. Any other question? One last question maybe there. Can you identify yourself, please? We'll come back.
Hello. Yeah, my name is Sagar. I have some companies which are working for the hospital industries. So my question is that, if you look up around the nations, the education becomes very important for technology and innovations. Well, we are making some progress as far as, biochemistry is concerned. But education level, unless and until it is brought to the international level, like South Korea, Japan, other countries, Sweden, Norway, there, the health sector is progressing in a digital, in medical form, in diagnostic form, in a very high way. So if you talk of health and if you don't talk of innovation with best education, I think we are missing a bus. Thank you very much.
Anybody wants to comment? Okay.
Sir, even I want to speak on these lines only, that we are trying to handle so many problems in the health sector, but if we are targeting to move in an integrated manner, then the sector we should involve is education. We should target it at an initial level. So the education system in India has become outdated and very long and very cumbersome. We should try to instead, this is in regards to the concept of practicing nursing officers, that instead of using incompetent staff, we should try to generate more competent workforce in all the sectors by resetting our education system. So maybe a lot of problems can be avoided.
Yeah, young lady, I can just, briefly sum up what you are saying is 110% true. India lacks, a good education policy. India lacks even more in healthcare. In fact, these are the two sectors in which we spend the least. And of course, about defense, we don't want to talk about right now. So India is, has to find out its own ways, but point is very well taken. Next time, we will also get the education secretary for you. Thank you.
Thank you, sir.
One last question. I know you got your hand up. Yeah. Maybe you already stood up. So
I'm Dr. Aman Kumar. I'm the chief editor of Journal of Family Medicine and Primary Care. We published this journal for past 10 years. And a lot of literature on primary care you find from our journal, from Indian, South Asian, developing countries context. I'm also the national president of Academy of Family Physicians of India. So I heard very carefully what government's perspective on primary health care, the evolving scheme of things, and also what industry might have to offer in terms of technology, telemedicine, financial background and all. The missing link I find is, we not talk about primary care physicians. And this is entirely, missing in the whole documentation, discussion, advocacy, policy. We're talking from CHOs and telemedicine referrals to specialists as hospital. At the same time, we are talking about decreasing burden and decreasing specialist time at specialist hospitals. And also, in the understanding of comprehensive primary health care, we talk a lot about comprehensive primary health care, but practically, it's selective primary health care when we talk of NCDs, maternal child health. And we have to address this, and this somehow it calls a kind of disconnect. And unless you resolve medical issues, there's a difference between primary health care and primary care. And healthcare issues in the community itself, it's not just about referral and doing diagnostics. A lot of things, 90% of it can be done by a competent primary care physician or primary care team in the community level itself. I'm a practicing physician myself, so I know what is the pulse of community. So just kind of trying to find the gaps in this discussion we had today.
Yeah, I think Dr. Raman, your point is very well taken. We cannot do everything in isolation. And family physicians are very critical in this whole thing, and we have to work in an integrated manner, and that's how family medicine, you will find that it's taking more and more kind of importance over a period of time. So we have to work together, but primary care cannot be achieved in isolation. Thank you.
Dr. Mahajan, you have the last word.
Thank you very much. I think the point is very well made. It has been addressed to some degree. I think family physicians, as we used to know when we were little, are no longer there. And I think there are a lot of startups which have come up with innovative models using telemedicine. I know for one where I'm a little involved, that is called Mera Doc, where they have in-house MBBS doctors working as family physicians, taking the history first, both personal as well as family history, recording it digitally, so that on a repeat basis, the entire family, and we've seen this in the last 1 year that it's been there, and surprisingly, we felt that, it was only the pandemic which gave it impetus, but it hasn't flagged. It still continues to carry on. And because of the shortage of doctors and access, I think that access will be provided through telemedicine, and family physicians will form the basis, whether, it is digitally providing it at the health and wellness center or from someone's home, that, at least in this country, is the way that primary, so it has to be sewn into the entire primary care delivery system.
Absolutely. Dr. Mahajan, very well said. And I think that's a good place to try and conclude this session. I just want to thank Dr. Lal, for getting all of us together. Thank all of you for being here, engaging for the last 2 hours. And I'm going to come back and give it to Dr. Meenakshi. And I think also it's great to have FICCI, OMAG, and Nat Health all come together with the government. So I'm extremely optimistic that we will move forward on this one and we will experiment. But with that, I think we'll get some concluding remarks from Meenakshi Datta Ghosh. So thank you for joining us.
I am an unlettered rural woman. How do you, sir, reach out to me? That sums up the mood of the House today. I wish to congratulate FICCI, the ALVL Foundation, Nat Health, and OMAG for this very wonderful partnership that they have, knitted together. And I wish them every success. And we do believe that with push and pull, it's not easy. And you heard Dr. Lal in particular talk about the ground reality in our meetings, which I have been pushing to say that what you are claiming will not be found on the ground. And that's exactly what he has shown today. It is difficult, but I am sure that there's a time and tide in the affairs of men, and I think the time has now come. The second point I wish to make is that every cloud has a silver lining, and so did COVID. It showed the world, that the most wealthy nations are certainly not the most healthy nations. And it certainly proved and established time and time and time again that what was missing was coverage, outreach, and scale in the domain of primary health care. And that is why, that's one reason why we are all sitting here today. The other legacy of COVID, and I say this with a sense of responsibility given the years I've spent in the domain of health in India, is that I have been in meetings with heads of MCI and IMA who have said, over my dead body, will I ever allow an Ayurvedic practitioner to sit in the same room as me? And I have been witness to that. We have argued ourselves blue and black in the face. That was the time when I was doing the national population policy. And as you can see now, a legacy of COVID that has come to happen for the simple reason we need manpower. Something is better than nothing. The last impetus of COVID has just been identified by our, the gentleman there who raised the question, and the answer from Dr. Mahajan is that this impetus on family physicians, and I'm sure that with telemedicine it will go very far. So that is that's the first point I wish to say. Second, even though it's becoming very clear that when we say that HWCs, 1.2 lakh HWCs are operational, on the ground there's not very much to show, but although things are coming together. A time motion study that has been completed of a very small sample of HWCs which are already operational has brought out a number of things which we need to bear in mind if we are to move forward in this direction. One is there's such a complete change in work patterns and in the distribution of work between the preventive and promotive and promotional activities and on the one hand and the curative diagnostic activities on the other, but that inside the HWC there is very little integration, and that will come. It's a matter of time, and I'm sure it will come. But it's good to be alive to these things. Another conclusion from the time motion study of the HWCs is that almost 35% of time of the HR engaged in the HWCs in the current partnership is spent on data gathering and manual record keeping and reporting. Now that is because all the HWCs are not IT enabled. So I think that's a push in that direction is definitely required. The idea of the nurse practitioner, I personally believe that I think Tamil Nadu was the first to show it, to demonstrate this, that actually it is the nurse practitioner who becomes the most appropriate bridge between the prevention and promotion activities and the diagnostic and curative activities, because the nurse practitioner has a very holistic training, and she's able to be the voice of the patient as well as the voice of the HWC. So I do believe that we need to keep pressing for this. It will happen. The time has come. There's one thing I did not see any mention for maybe one of the speakers from Chhattisgarh. This public health labs. We have the NCDC in the Ministry of Health, and of course they have their public health labs going into all states and union territories. But somewhere, now that we have HWCs, somewhere there has to be some synergy and some kind of reporting. Ultimately, primary health care is lodged in population health estimates. So if population health estimates, we need our epidemiology and surveillance also needs to be going side by side. I mean, the whole thing about SARS and COVID showed that there was no reporting. They were all working in vertical straitjacket method. The CDC Atlanta visited India 2006 maybe to give advice about SARS, and they talked about their the hierarchy of public health laboratories that they have in the US, which is they have the national laboratories and they have the regional and referral laboratories, and then at the bottom they have the sentinel laboratories, which actually report in this hierarchy, and that is how they are able to, or they claim they are able to detect faster than others. About the point of education somebody raised, I would like to really, and I wish, I'm sure this partnership will use their experience moving forward to press this with the Ministry of Health. We have recorded it there. Sri Lanka showed in 1960 that they would go to the villages and they would find out families who have daughters who are in high school, and they would identify those girls who have reached class 8 and slowly reaching class 10. And then they would, with the permission of the parents, prize those girls out of school and put them into nursing training. So that with a class 8 school education, they would give them a high school diploma. They would also, at the end of 1 year, 2 years, 3 years, whatever they needed or wanted or were prepared to sacrifice in terms of time, they would also give them a nursing diploma. And that is how you had nurses from Sri Lanka. And I think this point about education, this is where you can link up very easily. Last, I spoke to Secretary Health just now before he left. I would like to say, probably we are fortunate that we do not yet have a public health law. And the reason I say this with a sense of responsibility is that the public health laws in most countries, they have benefited while they were there, are now today being found inflexible. For the reason that, as we have seen, problems of health and healthcare and health delivery are becoming so complex that they are beyond the domain of the Ministry of Health. For example, you want to curb smoking, but it's a totally different ministry which is going to impose or increase and continue to increase the taxes on tobacco products. You want to, there was, WHO not very long ago declared a year of road accidents because India had the highest road accidents in the world and blah, blah, blah. So they came and they said that, can we not talk to, automobile, manufacturers? At least the airbags should be safer, the car seats should be safer, child safety car seats must be imposed in India. That was so many years ago, and it has not happened. So, but Sweden has shown a way where this cross-sectoral dialogue is actually sorting out problems of health. There's a new concept I have shared with Dr. Lal, and this is the last point I'm making. It is called H, small I, capital A and P. Capital H, small I, capital A and P. Health in all policies. This was pioneered by Finland when Finland for 1 year had the chair of WHO in the late 90s. Countries have taken it up. WHO has developed guidelines for it. We in India should ask for guidelines for HIAP. And I think the concept of HIAP should come into the public health law so that you who are running HWCs will henceforth by law be able to go directly to the concerned sector and be able to dialogue. So I think that is something that you... Thank you very much, and hearty congratulations once again. The time has come, and this is a very, very worthy effort. Thank you.
Dr. Agarwal, will you provide a vote of thanks, and then we have lunch?
Good afternoon, all my dignitaries on the dais, in front of me, my colleagues, and all the participants. I am fully aware of the fact that we have already overshot the time, and I promise I will take only 3 minutes or less than 3 minutes. No doubt that India is a unique country. We are having our vastness of geographical borders, vastness of numbers. And let me also accept one fact that the concept of primary health, which was discussed in WHO long back, but India has taken it right from the beginning in the primary health. And I always tell my colleague, Dr. Swinner, we have been working together, that out of the long year experience, what is more important, that we should come out with our experience that should become a learning resource not only for us, but for the entire globe. And that is the strength of India, that whatever experience, whether it's negative or positive, should become the experience for the entire globe. That is our strength. Well, PSC supported by National Health Policy document, then the declaration for the 1,50,000 centers gave us a different directions. And those directions, if we wanted success, that is what we were discussing. Needless to say that there has to be very strong partnership between government as well as the industry as well as the non-government organization. And we know it very well. Technology development we have discussed in detail, as well as the teleconsult, medical consultation is very important part. Allied health group, skill development, Dr. Meenakshi Datta Ghosh, skill development among each one of us. Whether I am a teacher, I am an allied health group. That is the most, and that is what we have been discussing in our FICCI platform also. So this workshop, which we have been hearing for last 2.5 hours patiently, I can appreciate the entire audience has been wonderful audience, and we would like to convey thanks to our Secretary Health, Mr. Rajesh Bhushan ji, who had to leave, but he has given us very important advice, directions, and his own vision, supported by his colleague from UP, Amit Mohan Prasad ji, and then Mr. Neeraj from Chhattisgarh. Our special thanks to Madam U, Meenakshi Datta. We have been associated for last 2 decades when Madam was looking after very important activities, say in NACO and all, and she has a very, very open vision, and she knows in depth what is the problem of our country. Needless to say that our chair, Dr. Arvind Lal, he is my neighbor also, and fully supported. I always say that there is always a lady behind success of a man, and here is Madam Lal, her presence. We like to convey our thanks to Sanjeev Navangul, who is the chairman of Net Health. What is more important, what we have found today, is now FICCI is involved in Net Health and OMAG, a partnership which will definitely help us in achieving our goal. When we talk about 1,50,000 centers, Herculean task, perhaps the biggest task all over the globe. And we have started. There are hurdles. Dr. Arvind Lal did mention that these are the shortcomings. Sunila always says gap finding. What are the gaps? And then try to fulfill it. That is very important. So, Sanjeev, thank you very much. Of course, and needless to, I will not say thanks to Sunila, my colleague, my friend. Dr. Ajay, co-chair Primary Health Care Subgroup of FICCI and the co-founder and CEO International Global Health System. Dr. Sunil Raina, who has joined us from Kangra, who is the head of the community medicine. It's a wonderful medical college, beautiful location. Dr. Harsh, कभी मौका लगे तो कांगड़ा जरूर जाना, बहुत सुंदर लोकेशन पे है. Thank you, Dr. Sunil Raina. Of course, Mr. Suresh Vijrani, co-chairman of Trans-Asia Urban Group. Technology is one which we have to adopt. Our thanks to our partner Net Health, Mr. Siddharth Bhattacharya, the Secretary General. We have already acknowledged OMAG through Sunila and Sunil. Our knowledge partner, Karan. Karan, thank you very much. We appreciate the contribution of Bain and Company through your leadership. And again, our principal support partner, AB-HWCs, ALVL Foundation, Sir Dr. Arvind Lal and Vandana ji, for giving a direction. Your experience of Uttarakhand is very important. I always say, try to create a success story and rest other people will follow it automatically. Our support partners, we have already Mr. Shravan, Dr. Shravan Subramaniam, and again Mr. Suresh Vijrani. I would like to say thanks to all my delegates, my colleagues. Some of my colleagues are here from Maulana Dad also, and each one of you. Needless to say that our this activity is being covered by the media, and thank you very much for a wonderful coverage. I'd like to convey my thanks to our DG, Arun Chawla ji, and certainly the most important thanks goes to Mr. Praveen Mittal and the entire team who is responsible for bringing this activity to all of us as a useful activity. And this is a very good beginning that we are having a partnership between FICCI, NetHealth and OMEG. And we'll definitely try to add whatever suggestions are there, and that will bring the best possible outcome. Thank you very much.
Thank you to all the speakers and our distinguished delegates for joining us. Please join us for lunch outside.